This is the presentation portion of the sign-off for ketamine administration. In addition to watching this presentation, you'll also have to complete the Google Forms quiz and do an in-person skill sign-off with either EMS staff at the clinic or with your district EMS coordinator. So what does ketamine do? It's an anesthesia agent, which means it provides a loss of awareness for the patient, as well as an analgesia agent. It has a pain blocking effect. So how does it work? The short answer is nobody really knows. However, it works as an antagonist in the NMDA receptors, HCN1 receptors, and L-type CA2 positive receptors. These are all receptors that are found in nerve cells in the brain and are responsible for many functions, including memory creation. When these receptors are blocked, an anesthetic effect is triggered. Ketamine also decreases neurocommunication between the thalamus and the cerebral cortex, which has the dissociative response. It also stimulates the limbic system, which leads to vivid dreams, hallucinations, and intense feelings. So when do we use ketamine? There's going to be a few indications in the field. Most commonly will be severe pain. It might also be used as a sedation agent for a patient in excited delirium, and in very select circumstances it may be used as an agent for procedural sedation in the field. There's a general division between sedation, or the knock 'em out approach, and the subdissociative, or the make 'em happy but not quite knock 'em out approach. We'll go into more detail on these later. So what can go wrong with ketamine administration? Our most significant concern in the field is respiratory depression. This happens significantly less than with narcotic painkillers, but is still the most significant side effect we might see in the pre-hospital setting. Occurrence varies significantly with administration route and dose. Respiratory depression is rarely seen with lower dissociative doses, though it is possible. With sedation doses, the slower and more controlled the administration, the less likely this is to happen. In studies showing the effectiveness of an IM dose of ketamine for combative patients experiencing excited delirium, a relatively high number experience respiratory depression. In controlled clinical settings where the dose and absorption of the medication is more controlled, there are fewer reported cases with respiratory depression. Regardless of how or why you're administering ketamine, be prepared to assist ventilations and manage the airway. End-tidal CO2 monitoring is required on any sedated patient and recommended for any use of ketamine. Additionally, other airway complications may present themselves. There is a risk of laryngospasms with patients, particularly in patients with a history of tracheal surgeries or tracheal stenosis. If a patient experiences respiratory depression and the provider is unable to intubate or use an LMA to successfully ventilate a patient, consider a cricothyrotomy, or, if possible, continue bag valve masking the patient until the side effect wears off. Laryngospasms are seen most frequently with surgeries of the upper airway, where the patient is consciously sedated for stitches or other procedures that repeatedly stimulate the area. Additionally, additional side effects include elevated blood pressure and pulse, which in patients with a history of cardiac disease can place an undesirable increase in the myocardial oxygen demand. Another significant side effect to be aware of is prolonged emergence from anesthesia. This is the only side effect that clinical studies and papers have determined an occurrence rate of, and the occurrence rate for this is 12% from sedated patients. Patients emerging from anesthesia during which ketamine was used, particularly as the initial induction agent, have had reactions that include confusion, delirium, excitement, hallucinations, and irrational behavior. This is probably the best known side effect of ketamine, There is a belief that ketamine makes people go nuts whenever it is administered. There is evidence that the calmer and more controlled the setting is when the patient is administered, the less likely the patient is to experience these symptoms once ketamine is withheld. Other side effects of ketamine administration include muscle tremors, nausea and vomiting, blurry vision or light sensitivity. With higher doses particularly, it may be beneficial to dim lights or reduce visual stimuli. If you look through papers on ketamine, there are many other side effects listed. Most of these are seen with prolonged use or abuse of ketamine and not in a pre-hospital acute pain management setting. Some of these include dependence, diabetes, bladder dysfunction, and a whole host of others. There are a few other interactions to be aware of when using ketamine, and plenty of good trivia to be included as well. Ketamine may decrease bronchospasms, and because of this, it is a preferred induction agent if you are intubating or RSIing a severe asthma patient. As we talked about a couple slides ago, there is an increase in blood pressure and pulse, there is a consequent increase in myocardial oxygen demand. Monitor the patient, and ketamine should be administered with caution in any patient that has a cardiac history. There is no reversal agent for ketamine. Side effects can generally be managed with supportive care, and the medication is relatively quickly eliminated from the body. Ketamine may also have an antiviral effect against rabies, so if you are inducing a coma in a patient who is a rabies patient, go to ketamine. There are many other proposed uses and interactions with ketamine, and many of its properties are still not well understood. So different clinical studies and trials have shown some varying side effects or interactions. So we'll jump back to talking about the different groups and dosings of ketamine, starting with the subdissociative dose. The subdissociative dose is given for pain management, and the goal of ketamine administration in these scenarios is to reduce the patient's perception of pain by creating a slight dissociation or break between the patient's mind and body. The patient will remain alert and able to perceive the pain, but will not care or be as affected as much by it due to the partial dissociation between the mind and body. Ketamine at this dose is most effective with simultaneous administration of a narcotic. This cocktail numbs the pain while also lowering the mind's ability to sense or care about the pain. There is also evidence that ketamine has an opiate-sparing effect, meaning an equivalent dose of a narcotic medication is more effective and lasts longer when given with or after ketamine administration. When co-dosing, be mindful of the different time frames for repeat doses. Ketamine is faster acting than the narcotics carried by Yosemite EMS, so to maintain a given level of pain management during transport, you will likely be redosing ketamine at a different frequency than the narcotic. Make sure to consult medical control for appropriate dosing parameters for repeat doses. Ketamine alone may be an appropriate choice for pain management in certain situations, such as the patient is unable to tolerate narcotic medications, whether because of an allergy, because they're a recovering addict, or a host of other reasons that the patient can come up with. There may also be concern for low blood pressure. Narcotics have a side effect of dropping blood pressure further, whereas ketamine, if anything, may raise the blood pressure. So ketamine is an excellent pain management option with patients who have a low blood pressure, as it does not carry the side effect of further lowering it. However, if there is suspicion that the patient may have a head injury, ketamine has not been recommended due to its potential to raise intracranial pressure, or ICP. There is the same concern for eye injuries, in that it might raise the pressure further within the eyeball. However, newer studies have shown that there is not actually an appreciative rise in ICP with traumatic head injuries and ketamine administration. Bottom line is to use caution with head injuries and eye injuries. Contact medical control prior to administration and consider the totality of the scene. So when is ketamine inappropriate for pain management? We've already discussed most of these, but just to review, if your patient has chest pain believed to be of cardiac origin, there's potential for an increase in myocardial oxygen demand, and these patients should not receive ketamine. Head injuries and eye injuries should be considered relative contraindications due to the increase in pressure, and medical control should be contacted prior to ketamine administration. Additionally, multisystem trauma is also a relative contraindication. If a patient has suffered a significant multisystem trauma, providers should have a heightened suspicion for hypovolemic shock and be more alert for early signs of compensated shock, such as increase in blood pressure, increased pulse rate, and mental status changes. If a patient is administered ketamine, they will likely have an increase in blood pressure and pulse, and may also begin to appear altered. Ketamine administration can mimic compensated shock, which may then mask early signs of shock in a patient with multisystem trauma. This is, however, a relative contraindication, and again, the specific events on scene and specific patient presentation, along with medical control consult, will dictate the best course of action. So what does a typical ketamine subdissociative state look like? Generally, the patient remains responsive and able to communicate when spoken to. The patient will still probably identify the pain when asked about it, but is not spontaneously aware of the pain. Patients also appear that they know the injury should hurt, but doesn't necessarily identify or care about the pain. Another thing to note is that the hallucinogenic recreational dose is extremely close to the subdissociative analgesic dose. You can expect some strange conversations to be going on. The patient will maintain their airway reflexes, such as coughing and swallowing, and the respiratory drive. Blood pressure and pulse will be slightly elevated, and a good sign to watch for is nystagmus. When a patient begins to display nystagmus, they are at the line between the sub and actual dissociation dose. So when you administer ketamine, if your patient begins to get some eye twitching, you'll know that that is the dose that you do not want to go over to achieve the desired results.